start with the case. This is a 63-year-old patient with chest pain and exertion. He had a cardiac CT done, and these are the images from the CT. The plaque here in the LAD, here in the circumflex, and in the right coronary artery. The question is, which plaque should we be most concerned with? So this plaque in the LAD is going into the diagonal branch, as you can see right here. So which should we be most concerned with? And before we answer that question, let's think about it. Which plaque is which? So now you have different kinds of plaque. This is here, you're seeing a tight focal plaque, which causes focal stenosis, and there's a correlating pressure drop within the vessel that causes ischemia. In this situation, you have a diffuse atherosclerosis, high plaque burden, also causes pressure drop, but it's much more gradual. So which is more should we be concerned about, right? And here, this is a plot that shows you the relationship between flow reserve and the area stenosis. We know that once the stenosis goes beyond 80%, the flow reserve goes down. But in this category where it is moderate, the flow can be normal or can be decreased. So that's where the conundrum is. We also know that when there is high-grade stenosis, that it's bad prognosis across all kinds of patient populations. And this is showing that when you have disease in multiple vessels, so these are 1 vessel, 2 vessel, and 3 vessels, there's increasing risk of events, cardiac events, death and not death, but infarction. However, you also see increased risk of events in the case of non-obstructive plaque. And why is that? Can plaque characteristics tell us more about the patient's risk? If you look at the CT imaging here, you have different kinds of plaque in all of these different patients. So this is more calcified. Here you see more of a non-calcific plaque. Here it's more mixed calcification. Are these plaques all going to behave the same? The plaques that look different behave differently. So what are these characteristics that we should be thinking about? And here is a nice summary, something that you might want to remember. Yes, of course, stenosis that is more than 50% is going to have there's a higher probability of having acute coronary syndromes. But from CT imaging, these are the features that you want to remember. Positive remodeling, wherein the vessel is actually growing, is expanding to accommodate the growing plaque. Low Hounsfield units, which is defined as less than 30. That is essentially lipid. And napkin ring sign is a correlate for vulnerable plaque with thin cap fibroathyroma and spotty calcification. These are the features that are considered as high-risk plaque. Now, we know that when you have more than 2 plaques, there's significant increase in the event rate. More importantly, if you can see plaque progression, that actually makes it much more significant. So this is look at the difference between high-risk plaques and plaques which actually progress. So going back to that case, so you have here a high-grade stenosis, a plaque which is low attenuation plaque. Also, it is diffuse, and there is a smaller lumen. In the diagonal branch, you have spotty calcification, positive remodeling, and the plaque burden is moderate. So when you look at this other plaque in the right coronary artery, so it's moderate stenosis. It's a little bit less plaque burden compared to this. So these are all the terms that we use to describe the different kinds of plaque, and they have a meaning when you say low attenuation plaque. So negative remodeling is not a high-risk feature. Positive remodeling is. We also know that with CT, if you just look at stenosis alone, greater than 50%, and correlate it with, they're not necessarily hemodynamically significant. More than 75% of the lesions that you call significant anatomically may not necessarily be significant physiologically. So only one of these lesions is significant hemodynamically. So can we assess ischemia and physiological significance? And yes, of course, the CT-FF, especially in the FFR-guided interventions, we definitely want to look at physiology. Without physiology, we really can't tell patients or tell whether to treat or not from a interventional standpoint. So we do want to know physiology. And CTFFR is a AI-enabled technology that is available. I understand it's not available here, but it is an add-on technology that doesn't really require any additional scan acquisitions. It's a post-processing software that they can do and give us the numbers. It's been well validated. Multiple studies have been done. And it compares well to the invasive FFR. It improves specificity and improves the cath yield. It, in fact, has a 2A indication in any lesion that may be significant according to the new guidelines. Now, so there is a study that looked at which is important, like the ischemia or plaque assessment, my topic, was studied in this study called Credence. And what they did in Credence was they looked at an integrated functional approach, meaning a stress test, not just the ischemia and ischemic burden, but also the ejection fraction, wall motion, exercise performance. They used all of that and compared it against information that you get from CT, which includes stenosis and all these plaque characteristics we just discussed and FFR CT. And they compared it against invasive FFR. And clearly CTA had a significantly higher area under the curve, was superior to the perfusion approach, even when you combine all the information that you get from there. Moreover, when they looked at it in more detail, if you just looked at stenosis severity, the AUC was 0.82. If you combine the plaque information, it was 0.88. And when you add on physiology on top of the plaque-related information, it was 0.89. This was actually not significant. So in this study, they concluded that a comprehensive anatomical interpretation with CTA, including quantification and obstructive and non-obstructive atherosclerotic plaque, was superior to functional imaging in the diagnosis of invasive FFR. Now, they also looked at the same variables and looked at the prognostic value from the ischemia study. And you can see that a lot of the plaque characteristics we discussed, including the plaque volume, low density plaque, low diffuseness of the plaque, remodeling index, and number of high-risk plaques, they were all significantly associated with a higher hazard risk. But now look at this other study, Emerald study, which is a retrospective study. What they did here was they looked at both plaque characteristics, plaque stenosis, and then looked at the add-on value of the physiology information. And what they found was that it actually was helpful to have when physiology was added, it actually helped them to predict events much better. They also indicate that, when you have from the study, that plaque rupture is really related to plaque, not only just plaque composition and organization, which indicates the vulnerability, but also lesion geometry and external hemodynamic forces, all of which information can be derived from these computational models and can predict the risk. So in Credence, they used stenosis severity, the number of lesions, the amount of non-calcified plaque volume, and the lumen volume to derive these scores to predict the atherosclerotic risk, and of course the high-risk plaque. So now there are commercially available third-party post-processing software which use AI and deep learning techniques, and they incorporate all these multiple variables. As you can imagine, it's hard to clinically for an individual to report all of this, but all this data is integrated, and this commercial software that is giving you the risk of this patient. And HeartFlow and Clearly are the two companies that do it in the US. And again, both of them are, one of them, HeartFlow, has been around for a while. And this is the direction of technology at the moment. So the question is ischemia or high-risk plaque features. So which one do you want to go? And I think the bigger question is, what are we asking? Are we treating ischemic symptoms? I mean, are we trying to decide, are we going to treat medically or revascularization? Or are we looking to lower future risk? Are we talking about prevention, lipid lowering, aggressive lifestyle changes? Or are we looking at both? So, and overall, we need to really integrate the anatomy, hemodynamics, and plaque characteristics because they help us both predict the risk as well as guide management. So I would say you need all of them, and it's not one or the other. So I have some time. If you have any questions, I'm happy to answer. Yeah.